So it is coming on 12 noon. Sorry, on 11. Apologies. It is coming on 11. Today we are coming to you at a special time because as most of you probably know, there is a webinar at 12 noon, which we felt that was important for people to attend the webinar, which is on the new referral portal at the MUHC. So this is what you will be using to send consults out, and it's really an important webinar. So we hope you all attend that at 12 noon. And for that reason, we welcome you to Medical Ground Rounds at 11 a.m. today. It's a pleasure to have everyone join us here. We are in person. For those of you who are at the Glen, you're welcome to join us in D02-1312. Otherwise, stay where you are and join us online. Just a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Just a reminder to please enter your questions in the chat at the end of the presentation, and please answer a brief survey that will be made available to you, be sent by email. This will let us know that you were present today. And finally, our speaker today is courtesy of the Division of Nephrology, and I would like to ask Dr. Rita Suri, the Chief of the Division, to introduce our speaker. Thank you.
Thank you, Nadia, and thank you to the Department of Medicine for giving us the opportunity to present Grand Rounds. Today, it is my great pleasure to introduce to you Dr. Tomoko Takano, who many of you know, but I will just go through for those of you who don't, her significant accomplishments in science and in nephrology over the last few decades. So Dr. Takano is a senior scientist at the RI-MUHC and professor of medicine in the Department of Medicine and a member of the Division of Nephrology. She is a very active and prolific basic scientist who is an expert on podocyte biology and has helped to uncover some of the immune mechanisms related to nephrotic syndrome, a very significant disease in nephrology, and these are significant breakthroughs. And for her work, she was recently awarded the prestigious Kidney Foundation of Canada Medal of Research Excellence. And so we are super proud of Tomoko for that. She also serves as a co-director of the MUHC Kidney Disease Biorepository and founded the Canadian Kidney Discovery Network and serves as a mentor to many basic scientists across the country. And finally, she is the current president of the CSN. Today, she will be talking to us about glomerulonephritis updates, and so I will hand it over to her, and thank you for presenting to us.
Okay, good morning, everybody. Thank you, Dr. Janetti and Dr. Suri for the kind introduction. And thank you, everybody, for coming to this unusual time because of the time conflict. Although I'm a bench scientist, because this is a medical ground round, I try to prepare the glomerulonephritis update framing in the clinical context. So this is the learning objectives which have been circulated. And I have some conflicts, but nothing to do with today's presentation. Okay, so glomerulonephritis, I'm sure you're familiar with the term, usually abbreviated as GN, that refers to a group of diseases that primarily affect the glomerulus, which is a filtration unit of the kidney here. So you see the afferent arteriole, the blood is going through the capillary tangles here. And here is Bowman's capsule surrounding these capillaries and then leading to the proximal tubule. So this will lead into the final urine. So although nephritis indicates inflammation, it's not necessarily the case, and GN includes a lot, almost everything that affects primarily the glomerulus. Now, why is it important? First of all, the true incidence of glomerular disease at the time of onset is largely unknown. It's because the disease, many diseases start very quietly, and the biopsy practice varies so much around locally, even between the MGH and LVH at the MUHC, the practice differs. So you can imagine how variable the biopsy practice is. But if you put together all the glomerulonephritis, it accounts for approximately 20% of end-stage renal disease in developed countries. So here at the Canadian data and glomerulonephritis here, the top is diabetes, diabetic nephropathy, but nonetheless, it's not negligible. If you count every single category of GN, it's rare, but putting together, it's a fairly common cause of end-stage kidney disease, and that's why it's important. The problem of the classification of glomerulonephritis, probably you are aware, is that the nomenclature is really confusing. So it can be labeled with a clinical presentation with hematuria, proteinuria, so nephrotic syndrome versus nephritic syndrome, or a clinical picture of AKI of a rapidly progressive glomerulonephritis. The other set of terms are histological patterns like minimal change disease, focal segmental glomerulonephritis disease, membranous nephropathy. And some other names can be from the real pathogenesis, anti-GBM disease or ANCA-associated vasculitis. Even for nephrologists, it's confusing, and I can only imagine how confusing this might be to non-nephrologists. The field is trying to come up with a more pathogenesis-based classification, and I tried to find something that is appealing to the general audience, but I failed. I couldn't find anything convincing. So I will stick to this traditional spectrum disease, the courtesy of Dr. Samantha. So in this one, the left side represents nephrotic syndrome, so proteinuria dominant picture, and the right side represents nephritic syndrome, hematuria dominant disease, often coming with kidney injury or hypertension, some other clinical symptoms. Along this spectrum, way on the left side, as minimal change disease, or focal segmental glomerulonephritis, glomerulosclerosis, FSGS, or membranous nephropathy. These are the representative primary glomerular disease, which usually show as nephrotic syndrome. And after that, diabetic nephropathy, amyloidosis, these are considered to be secondary. They often present as nephrotic syndrome, but it's not usually considered as primary glomerulonephritis. And way to the right, the extreme one is anti-GBM disease, usually very aggressive. We treat with our dermatology colleagues often, and quite often have end-stage renal disease, and other vasculitis or post-infectious disease also come to this spectrum. And spreading all over the place is lupus nephritis, SLE, which I'm not going to cover today. It's just too big to cover. And IgA nephropathy, which is very common and usually goes towards the nephritic hematuria dominant phenotype. So I listed the main diagnosis of glomerulonephritis and key progress. So among the nephrotic syndrome, protein dominant phenotype, minimal change disease, FSGS, it's too cumbersome to spell it out, so I will say it one more time and I will stop saying it. Focal segmental glomerulonephritis, FSGS, or membranous nephropathy. These are the representative main diagnosis of nephrotic syndrome. Now, nephritic syndrome, there are many, but the common ones are IgA nephropathy, and we are seeing more and more ANCA-associated vasculitis, anti-GBM disease. As I said, lupus nephritis can present in any phenotype, but I'm not going to talk about it. And also the thrombotic microangiopathy, the spectrum has been really developing, and it's a huge topic. I'm not going to cover that. This one is not considered to be glomerulonephritis, but it does affect the glomerulus. Now, in each category, what's been happening in the last 10, 15 years? So first of all, there had been some development in the understanding of pathogenesis of minimal change disease and FSGS. I'm going to talk about that a little bit. Membranous nephropathy, it's already recognized as auto antibody induced disease, and more antigens have been recognized. In addition to PLA2 receptor, which is routinely measured for nephrotic syndrome, now we have 7 or 8 antigen recognized, but not all of them are available as assay. In the nephritic side, I'm going to talk about IgA nephropathy, mainly the development of treatment. This is the most active area of clinical trials in nephrology right now. And ANCA-associated vasculitis and anti-GVM, there have been some development in treatment, mainly targeting B cells using anti-CD20, but I am not going to talk about that. And finally, I want to emphasize that this category, C3GN, this spectrum of disease is now clearly recognized as clinical entity, emphasizing the role of complement in the glomerulonephritis. So if I am to summarize the key progress in glomerulonephritis, number one, the pathogenesis, almost all primary GN is now considered to be clearly autoimmune disease. This has been suspected for a long time, but now we have more and more data. In terms of treatment, there have been a lot of treatments developing, but the main two areas are the number one, B cell targeting drugs. So anti-CD20 is routinely used now and others as well. And it covers minimal change, FSGS, membranous, ANCA, anti-GVM. All these diseases are now treated with anti-CD20. Complement inhibitors, the eculizumab, the most expensive one, has been already used, and avacopan is now increasingly used. The complement, I think Dr. Samantha gave a great medical ground round not long time ago, so I'm going to skip over entirely the role of complement. But inhibitors are really getting more and more common. And the role of genetics, I think in glomerulonephritis, we used to think that we have no treatment, therefore not much point trying to identify the genetic cause, etc. But that is not true anymore. So we are doing more genetic tests in the GN. Okay, so what I tried to do, initially I thought of giving you all the data from my lab, but instead I decided to focus on 3 disease areas: minimal change disease, primary FSGS, and IgA nephropathy. These are the disease categories which had great progress in the last 10, 15 years. And I also I had interesting cases for each category. So I will present a case and give you highlights of each disease category. Okay, so this is the first case. 36-year-old Caucasian lady. She came to our emergency room with progressive leg edema over a couple of weeks, and she was otherwise very healthy, no recent infections or medication changes. So she was really swollen out of the blue, but otherwise well. Blood pressure was normal, but she was really anasalgic. And urine protein was 12 gram per gram, so clearly nephrotic range proteinuria with serum albumin 22. Creatinine was normal. So this lady has clear nephrotic syndrome. There was no hematuria in urinalysis, and the biopsy was done. This is not hers, but it looks like, hers looked like this. So this is a typical biopsy finding of minimal change disease. So light microscopy, absolutely no abnormality, beautiful. And immunofluorescence, no deposition. This I have to come back a little later, but the report, her report said that there was nothing, IgG-AM complement, light chains. But electron microscopy showed very diffuse foot process effacements of podocytes. So this is a typical presentation of minimal change disease. So clinically, it presents with rapid onset of nephrotic syndrome, and the first line treatment is glucocorticoids. In adults, usually prednisone. And second line agent, cyclophosphamide is so recommended in the guideline, but we don't really use it anymore. Often calcineurin inhibitors or MMF, And if difficult to treat cases, rituximab is used. I'll come back to that later. So the pathogenesis of minimal change disease was unknown more than 5 decades. It was a complete mystery. It was recognized as a mysterious disease because if you look at the kidney biopsy, there's no sign of renal inflammation and no IgG deposition has been clearly documented. Now there's a question mark for that. That's why there's a color on it. No complement deposition, no immune cell infiltration. So no sign of inflammation or immune response, yet the disease responds so sharply to glucocorticoids. It is so in adults, but it's more prominent in children. Most children with idiopathic nephrotic syndrome present with this disease, minimal change disease, and they respond to steroid very, very sharply. Within a week, they remit. Okay, so what is happening in the glomerulus? So the only histological feature we see in minimal change disease is a food process effacement. So here is a capillary wall, so glomerular basement membrane. This is a capillary side, and here is the processes from podocytes which surround the glomerular capillary from outside. They have very thin processes and called foot processes. They look like feet, and foot processes from adjacent podocytes interdigitate and get connected with a membrane-like structure called slit diaphragm here. And the filtration of blood occurs from here through the slit diaphragm into the urinary space. So what's called the food process effacement this is a completely normal looking food processes, and this is a minimal change food processes, completely effused. So this is the typical feature. And for many, many years, the hypothesis has been that since the disease responds to the glucocorticoid, and there are many other circumstantial evidence, T cells must be making something that's circulating in the body and affects podocyte, which causes food process effacement. So that was a dogma for over 5 decades. This started to change So this such a humoral factor or circulating factor has been proposed, and I just listed a couple of things that had been proposed in the last 5 decades. Some of them were published in New England Medicine, 2 papers in Nature Medicine. So it's not like a trivial contribution. Many people claim that they did find this mysterious circulating factor, but none of them really stuck. So we couldn't prove that any of them were truly pathogenic in minimal change disease. So this started to change about 10, 15 years ago. So the first one, interesting one in 2004. So this is a case report in pediatric nephrology. 16-year-old girl who had frequently relapsing nephrotic syndrome 35 times since age 2. It's crazy. Developed ITP. It used to be called idiopathic thrombocytopenic purpura. It's now called immunological, thrombocytic purpura, thrombocytopenic purpura. So it's really an autoantibody-mediated platelet disruption. So this patient received rituximab to treat ITP, and then miraculously the disease stopped relapsing. So after 35 of relapses, treated with various medications, she just stopped relapsing. So that was the first very illuminating case report. And 10 years later, in 2014, this clinical trial was published in Lancet by a Japanese group. So this is a pediatric nephrotic syndrome, so mostly minimal change disease. And one arm received rituximab after remission was induced by steroid. So that's a blue one. And the control arm just received a steroid. And the y-axis is showing the relapse-free survival. So those children who received rituximab remained in remission for much longer period of time. So this was a landmark study which put B cells in the center of pathogenesis, not T cells. And what do B cells do? Generally speaking, they make antibodies. But what is that antibody? That was not known for another 10 years. So I have to introduce the protein called nephrin. So this is a structural backbone of the slit diaphragm here. So they are sticking from the membrane. It's a transmembrane protein discovered by a genetic study in 1998 by a group in Sweden. And its mutation causes congenital nephrotic syndrome of Finnish type, very severe nephrotic syndrome. And this protein was discovered to be the target of autoantibody in minimal change disease. So the first discovery report was 2022 on Jason, and here is the main data. So this is a healthy individual, minimal change disease, and this is a membranous nephropathy patient with anti-PLA2 receptor antibody positivity. And see that the 18 out of 62 patients was positive for anti-Nephrin antibody. And about a little bit over 1 year, another study was published in New England. This time, so the first paper was from Brigham and Women's Hospital in Boston, and the second one from the European Bigger Consortium. And here, the minimal change disease, about 40% positivity. And interestingly, the FSGS, primary FSGS, I'll come to it as a second case, was also positive in some patients for nephrin antibody. If you look at the pediatric population here, it's an INS, idiopathic nephrotic syndrome. And if the proteinuria is still in the nephrotic range, the positivity goes up. And if the child is untreated, the positivity goes up to almost 80%. So these papers together, so the conclusion of these papers and many others followed this finding, was that anti-Nephrin antibodies are present in the sera of children and adults with minimal change disease and primary FSGS. And in these patients, IgG was actually present in biopsies. I'll show the pictures. And anti-Nephrin is actually capable of nephrosis in the experimental setting. So this is the IF from the Brigham group. And you see the very diffuse green, which usually a pathologist considered non-specific. But you see the granular punctate one, and the Brigham group called them positive. And when the IgG was positive, actually the patient's serum was positive for anti-Nephrin antibody. And when the IgG was negative in biopsy, the serum antibody was negative. If they used a super resolution microscopy of antibody positive patient, so here on the left side, the green is IgG and red is Nephrin. And you see that they're overlapping with each other. On the right, they're staining IgG with another protein called synaptopodin. Synaptopodin is a podocyte protein, but it's not at the slit diaphragm. It's within the cytosol, so they don't overlap. So they concluded that these antibodies, the IgG, is binding to nephrin in the kidney. This is a bit of a busy slide, but just listing that anti-Nephrin antibody is pathogenic. So first of all, the major congenital nephrotic syndrome patients, they're born without nephrin. And then they get into renal failure very young, and they get transplanted with an intact nephrin. And these patients sometimes develop nephrotic syndrome. So this is clearly caused by anti-Nephrin. So that's one evidence. And there are many experimental models. So when you inject an anti-Nephrin antibody to rats or mice, it can cause nephrotic syndrome, minimal change, or sometimes FSGS. And in that second New England paper, they immunized mice with nephrin protein and induced proteinuria. The most conclusive one is the same group, European group. who purified anti-Nephrin antibody from patient serum. Apparently, the patient received plasmapheresis. So they were able to purify the IgG and inject into rabbit, and the rabbit became nephrotic. So all in all, the evidence is accumulating that anti-Nephrin antibody is pathogenic in minimal change disease and most likely in FSGS. So going back to the first case, this lady was very eager to collaborate with us in a research front. So anti-Nephrin antibody was positive at the onset. And she easily achieved remission with prednisone 1 milligram per kilo, and anti-Nephrin antibody became negative. And in the following 18 months, she relapsed 5 times, and each time anti-Nephrin antibody became positive. And she did not tolerate prednisone very well, many side effects. She did not want calcineurin inhibitors or MFF. So finally, I gave in and treated her with rituximab last summer. And after many months, she's still in remission, and I'm hoping that she'll be in remission for a long period of time by depleting a precursor of antibody depleting cells. Okay, so that was the first case. Now I'll move on to the second case. So this is a case of primary FSGS. I was only partially involved in the care, so there might be small pieces missing. 65 years old lady, Caucasian lady, presented with a progressive leg edema over a little longer period of time than the previous lady. When she came, blood pressure was high and she was really, really edematous. Proteinuria was 20 grams per day and serum albumin was 15 grams per liter, and creatinine was already elevated. A bunch of serologies were ordered for secondary causes and they were all negative. So the biopsy showed the typical picture of FSGS. So FSGS focal means some glomeruli are affected. So if you look at, this is not hers, but this is a typical FSGS picture. Some glomerulus is looking normal, some others are affected. The sclerotic lesion exists. So that's focal. And segmental means within one glomerulus, some parts are sclerosed, like here, and other parts are intact. So that's a segmental. So that's the origin of the name of FSGS. So this lady had a typical picture. Immunofluorescence was rather non-specific. IgM was stained, and also C3, C1q complement was stained in the sclerosed lesions. But the EM showed also, similar to minimal change, extensive foot process effacement. So again, this is a fairly typical presentation of what we call primary FSGS, and the first line treatment is glucocorticoids, and the second line is calcineurin inhibitors and MMF, rituximab, ACTH. These are in the recommendation. Because the clinical picture is really like a more severe and more difficult to treat minimal change disease, and usually takes much longer to remit, if at all, than minimal change, and more likely to reach end-stage renal disease. The statistics really vary a lot, but somewhere between 30 and 50% are considered to progress to end stage. And it's also known for post-transplant recurrence, also very high recurrence rate. Now, before moving on, I have to mention and emphasize that FSGS is a histological diagnosis. So you see the FSGS, but it doesn't mean that the patient has this immunologically driven primary FSGS. So that's here, primary FSGS. Histology look all the same, but this primary one, the feature is food processes are diffusely effaced. So that's the one. There's a genetically caused one. There's a secondary one, either virus, drugs like cocaine, or obesity, a bunch of other things, secondary FSGS, and undetermined cause. I don't know what it is, but so this was in the guideline, KDIGO guideline. It's a kidney disease improving global outcome. It's a go-to guideline for nephrologists. And even they admit that FSGS is a mixed basket. So that's why the statistics are really variable, because it depends. Variables, the numbers can change depending on which category or which patient is included in the stats. The other thing about the FSGS is that there is a considerable contribution of genetics. So there is a discussion when to test, when to do the genetic test. And if you ask the medical geneticist, usually if you don't find any secondary cause, just go for it. And even if you think that it might be secondary, if the patient is younger than 50, just to check the genetics. That's the advice you get. The advantage of having a genetic diagnosis is that you can avoid unnecessary immunosuppression. For example, if you think it's a primary, we treat up to 6 months with high dose corticoid, which is quite aggressive. So you want to avoid something like that if the diagnosis is genetic. Also, if the pregnancy is planned, genetic counseling will be important. And for pre-transplant, definitely it's worth doing it because primary tend to recur very highly. And the diagnostic yield of genetic test varies a lot. Hereditary nephrotic syndrome is very high, 70%. Pediatric cases, nephrotic syndrome, 20 to 30%, and adult nephrotic syndrome, 10%. It's not that high, but I think it's worth it. My practice, if I'm not sure if I'm dealing with primary or secondary, and if the patient is young, I usually ask for genetic test for FSGS. And this is an example of New England paper, over 3,000, mostly adult tested for kidney reason. And you can see that 1/3 is polycystic kidney disease, the final diagnosis. About 1/3 is collagen 4. So it's like Alport spectrum. And the remaining abnormality, 1/3, is the aggregate of 60. So there are more than 60 genes that are known to cause FSGS. Although the predominantly affected gene is collagen 4 gene, it's worth running this panel. Okay, and the other important aspect of FSGS is that they recur. So recurrence rate depends on the statistics, but 30 to 6%. And there's no predictive marker, that's the problem. This is a little old, but it's a very well-known case. So this young gentleman in the middle had primary FSGS, was on dialysis, received transplant from his sister on the right side here. And then within a short period of time, he had a recurrent disease. So the ethics are allowed to take the kidney out of this recipient and give it to the second recipient, this older gentleman of diabetic nephropathy. And this is what happens. So this is proteinuria. And in the first patient, the proteinuria rapidly increased. And this is when the allograft was taken out and put in the second patient. And the proteinuria disappeared and GFR really rapidly improved. So this was often used as a proof that idiopathic FSGS or primary FSGS is caused by something circulating in the body of the patient, in this case, the first recipient. But what was it? So nobody could nail it down. And then about more than 10 years later, so this is a study after the nephrin antibody was published in minimal change disease. This is from Japanese Pediatric Transplant Center, and they detected anti-Nephrin antibody in their transplant recipient. So here is FSGS who had a recurrent disease post-transplant. 11 out of 11 were positive for anti-Nephrin antibody. The next one is a non-recurrent FSGS. So the prior to transplant, the diagnosis was FSGS, but the patient did not have a recurrent disease. So only one had a very low titer and the others were negative. Genetic FSGS, 0, healthy individuals, 0, and disease control, including lupus nephritis, etc. There was no nephrin antibody detected. So this and a couple of other case studies clearly show that in some cases, anti-nephrin antibody is contributory, or at least predicting the recurrence of FSGS post-transplant. And this is the only data from our lab. So on the right, we confirm the anti-nephrin antibody in our cohort. So children and adults, minimal change and primary FSGS, we did see some nephrin positive antibody positivity. And we also studied another autoantibody. So here is a slit diaphragm, and red and pink is nephrin. And what's depicted in green is called CRIP2. That's another slit diaphragm protein, very similar structure to nephrin, right next to nephrin. And the congenital, gene mutation of this protein causes FSGS or nephrotic syndrome. So it's a very similar nephrin protein as nephrin in function. And what we saw is that in the same disease category, we did see anti-CRIP2 antibody. And what we found was that the titer and the prevalence of anti-CRIP2 antibody was highest in adults and in FSGS. So, and interestingly, many patients who were CRIP2 antibody positive were also positive for nephrin. So we are thinking that there might be some epitope spreading to a different slit diaphragm protein in FSGS. So this is to be confirmed. So this paper is currently in submission. Okay, so the current understanding of the pathogenesis of minimal change and primary FSGS, we think it's like this. Nephrin, CRIP2, there might be other proteins in the slit diaphragm. Somehow the tolerance is broken, autoantibody is made, antibody attacking these proteins that causes nephrotic syndrome. And what determines the disease severity is a big question which we are studying. If the patient relapses 35 times, it's possible that podocytes are gradually lost, and that may determine the severity, for example. Or it could be the severity of the immunological derangement, or maybe different protein or different epitope that is attacked or recognized by antibody, or epitope spreading, like in SLE. So these are work in progress. So going back to the case, the patient had a very super titer, high titer of both anti-nephrin and anti-CRIP2 antibody. This sample was taken just before she started dialysis. I think Dr. Takano helped us to get the sample to us, and it was really spread to different isotypes, IgG, AM. She did not respond very well to immunosuppression. And she was treated with prednisone, tacrolimus. For some reason, rituximab was never given. And she had multiple admission for anasalca and reached end stage and started dialysis 2 years after the diagnosis. And when I was going over the case, I realized that after 3.5 years on dialysis, she got transplanted last summer. And the most recent data, creatinine is 160, urine protein 1.5 to 2 gram per gram, and she's on tacrolimus and MMFs. So I'm really curious what her autoantibody status is and what her likelihood is for recurrence. I hope she won't recur, but we need to watch. Okay, so let me just move on to the last case. So I'll go quickly. So this is a case of IgA nephropathy. 45 years old lady from Philippines, and she was only known for dyslipidemia and referred to us for progressive rise of creatinine and proteinuria. She looked well, euvolemic, normotensive, even on the low side, but creatinine was 145, which rose from 85 2 years earlier, and UPCL was 7.7 grams. Serum albumin was holding at 32, so she wasn't quite nephrotic syndrome, but nonetheless, she had a significant nephrotic range proteinuria. And I didn't include here, but she had a very severe hematuria, microscopic, but hematuria. So her biopsy looked like this. This is an immunofluorescence staining for IgA, strong staining in the mesangial area. This is a signature IF for IgA nephropathy. Clinical presentation is quite variable, could be asymptomatic microscopic hematuria or plus minus hematuria, plus minus increased creatinine. Some cases can present with rapidly progressing GN or rarely TMA or nephrotic syndrome. So you can't really tell from the clinical presentation, and you need to biopsy. And sometimes a severe hematuria can occur following upper respiratory tract infection. Okay, so if you look globally, IgA nephropathy is the most common GM in the world, and this is a percentage among biopsied individuals. And you can see that the prevalence is really high in the Asian country, and this trend continues even after the patient moves. So this lady was from Philippines, where IgA was very common, so it was not surprising that she was diagnosed with IgA. Regarding the pathogenesis, it's sort of half understood, but not completely. Now, the main thinking is a 4-hit hypothesis. The IgA is normally galactosylated at the hinge lesion, and for some reason in patient, this galactosylation is impaired. It's called galactose deficient or Gd-IgA. This is generated in the lymph system in the intestine, in Peyer's patch, for example. And then in response to this abnormal IgA, secondary antibody is generated IgG or IgA that produces immune complex. And then this circulating immune complex finally find the final destination in the glomerular mesangium, and that causes inflammation. So this is a current understanding of the IgA nephropathy. Regarding the prognosis, there are many statistics that indicate that the degree of proteinuria predicts prognosis. So this is just one example. I could find 3 or 4 similar curves. So the top one slopes a relatively small amount of proteinuria, and the bottom one is more than 1.76 gram per gram. So the more recent data really indicates that there's no safe proteinuria. Yes, the lower the proteinuria is, the better, the prognosis is better, but there's absolutely no safe one. We used to say that less than 1 gram per gram is good, but not anymore. I think we're thinking that the lower the proteinuria is, the better the diagnosis. So the current treatment, number one, if you have proteinuria, significant proteinuria, then treat with glucocorticoid. So this is one of the clinical trials which clearly show the benefit of the treatment of glucocorticoid. The caveat of this paper or randomized controlled trial is that the population was predominantly Chinese, and there seems to be some variability in the treatment response depending on the ancestry of the patient. So this one is the current KDIGO IgA nephropathy guideline, just published last year, updated from the previous version. So if the patient is high risk, UPCL more than 0.5, half a gram per gram, then go to all this cascade. And you'll notice that the right side is the so-called supportive therapy, cardiovascular risk reduction, or blood pressure control, lifestyle modification. In terms of medications, RAS inhibitor, as in many other CKD, is used. And now the SGL2 inhibitor is becoming a standard. So this DEA-LA is double endothelin angiotensin receptor antagonist. So this was proven to be effective in IgA nephropathy, but it's not available yet in Canada. And there are so many of them. Clinical, like proven by LCT, not available yet in Canada, or available, but the government doesn't want to pay. So that kind of medication exists a lot. Now, the left side is fairly new in nephrology, not so much in oncology or rheumatology. It's trying to actually modify the disease cause, so disease modifying type of treatment. So here you see Nefecon, which is a steroid targeting the Peyer's patch. And this was proven to be effective in IgA nephropathy, clinical trial, and also systemic glucocorticoid. And depending on the country, China recommends MMF or chloroquine, and Japan recommends tonsillectomy, but this doesn't stick in North America. What's interesting is always consider the option of clinical trial. So this is in the guideline, summary statement. And when I looked, there are over 200 clinical trials going on in IgA nephropathy. So it does make sense. So this is all good, but probably not enough. And we need newer treatment. I'll just show you two of these newer treatments. So one, this is anti-APRIL. This was just published last year, the end of last year. So APRIL is a sort of cytokine which stimulates B cells through these receptors. And this sibeprenlimab, I really have a hard time pronouncing it, sibe, binds to circulating APRIL and blocks its binding to the receptor. And the clinical trial, this is a phase 3 interim analysis, showed a clear effect on the reduction of proteinuria by this drug up to 52 weeks. So that's 1 year. The second drug is a complement factor B inhibitor. So as you know, the complement, there's a classical pathway, lectin binding pathway, and alternative pathway. And factor B is one of the factors in this alternative pathway, and iptacopan inhibits this. And again, so this was published in New England 2024, phase 3 trial, and showed that iptacopan was effective in reducing proteinuria in IgA nephropathy. So although the guideline was updated last year, most likely it will be re-updated very soon, and the next version will likely include B-cell targeting drugs and complement inhibitors. But access to these drugs is a completely different issue, which we need to work on. Okay, so the summary of the, before the summary, the wrap-up of the case 3. So this lady was treated with a reduced dose of prednisone, which was recommended in that testing trial. That testing trial used methylprednisolone, and high-dose arm was prematurely terminated because of the side effect. And so they do recommend reduced dose, a relatively small dose of steroid. And to 6 to 8 months is a recommendation. And this lady received it about 9 months, including the tapering period. She was also treated with RAS blockade, ramipril, but didn't tolerate it because she ran into a hyperkalemia problem. And EMPA was started after, and 4 years after the diagnosis, creatinine is 230, which increased from her presentation, nonetheless stable for the last 18 months. And urine protein is stable around 1 to 2 grams. It's not below 0.5, but it's much better than what you used to have, more than 7 grams. And hopefully she will be stable for a much longer period of time. Okay, so this is the last slide of the glomerulonephritis take home. So most GNs are now recognized as autoimmune diseases, and new antibodies for minimal change and primary FSGS are recognized. Anti-Nephrin for sure, and some others, we and others have identifying. New drugs, especially B-cell targeting drugs, are used in most GN. and role of complements is increasingly recognized, and the use of complement inhibitors will likely expand in coming years. And the threshold for genetic tests should be lower than the current. I think I would strongly suggest that if you see FSGS, just go for the genetic test. Thank you for your attention.
Wonderful. Thank you so much for this very comprehensive review of a very important topic. I think that affects many, many of our patients. The floor is open for questions. I'm impressed by all the people in the room at this early 11 to 12 grand rounds. If there's any questions, you can enter them in the chat. Otherwise, I'm happy to take questions from the room. Go ahead.
Yeah, I'm a medical biochemistry in the central lab in charge of immunology testing. So do you think there will be a role for this, antibody anti-Nephrin in the clinical diagnosis and the follow-up of this patient?
The answer is, I believe so. And actually, I'm glad that you're asking, because I want to know how we can make the test available in the clinical lab. We are receiving samples from everywhere across Canada and internationally. They want anti-Nephrin antibody tested pre-transplant, and we're telling them that we can do it for research, not as a clinical. If there is any way to get this standardized and make it to the clinical lab, I think many people would appreciate that. So maybe offline we can discuss it.
Yeah, maybe I can go into your office to discuss how we can make a reach to the clinical lab.
Really welcome. I think I love that.
Thank you.
Other questions from the room? Yeah, go ahead.
How do patients with FSGS how do they respond in terms of anti-Nephrin antibody versus the minimal change patients?
Yeah, we don't have a big enough number to make a definitive statement, but generally speaking, FSGS patients don't go into remission as easily as minimal change. Their antibody titers tend to be higher than the threshold. So it seems that the disease activity and antibody titers go in parallel. But the numbers of FSGS is relatively small, so we can't really conclude it definitively.
Thomas, go ahead.
So follow-up question to what Serge just said. So do you think that that's a unifying hypothesis that you have minimal change in FSGS, primary FSGS, that are the same disease and are due to the same antibody, and the severity of the presentation is just immunological exposure and immunological titer?
Yes, that seems to be where the field is going. So there are some people who strongly believe that these are two different diseases, but this is partly affected by this feature of FSGS, which is morphological. So it's not easy to tease out what's called primary FSGS versus secondary genetics, etc. And I don't think genetics or secondary FSGS is in the spectrum with the minimal change disease. But this primary one, I think it's within the same spectrum.
For the non-nephrologists on this in this meeting, who do we refer, and when and how? Are we referring too late? Are we referring not enough? Are we referring too much of these patients? Can you just give me an idea what we should be doing?
Yeah, when the patient is nephrotic, they are referred to us very quickly. We get the referral in the emergency room. One of us will go and see. And depending on the severity, some patients come to any general nephrologist. When things get complicated, Dr. Samantha at the MGH has a GN clinic specializing in the complicated glomerular disease. So she is leading it. Dr. Samantha and I have a weekly meeting, identify patients. Right now, this autoantibody measurement is on research basis. So whenever we identify patients, we approach the patient for research study, get the sample collected, and the measurements are done in my lab. IgA nephropathy is a completely different story, and many patients might be followed by general medicine colleagues because they have very minor, many patients have simple microscopic hematuria. And probably it is a good idea to check proteinuria, and if there's anything over 0.5 gram, probably refer to us, please. Any of us, yeah.
So there has to be protein. If there's no proteinuria, you don't want to see patients.
Interesting question. We don't mind seeing them. We'll send the proteinuria. Yeah.
Yes, Rita?
Yeah, thanks for that presentation, that question. And just a follow up to that, just to what Dr. Takano said at the beginning, that, you know, these GNs are a very important cause of end-stage kidney disease, and in fact, have higher burden for the population, given that the majority of the patients are so young. So as Tomoko said, you know, if you have a youngish patient who has any degree of proteinuria, hematuria, please feel free. We won't refuse them.
Fantastic. So on that note, I think we're going to end these medical grand rounds because, as you know, we have another session. Any CKD referrals should include okay, yes, okay.
Yes,
Tina, yes, okay. We got the best. Thank you. Comment from Dr. Pottival there. Thank you very much. Okay, so there is a noon session, a webinar. The reason we have these grand rounds from 11 to 12 is that there is a noon webinar that Dr. Roger feels very strongly people should be attending. It is on the new referral portal that we need to use at the MUHC. For those of you who don't have the link, Sylvia, are you able to enter the link in the chat?
I'll find it.
Yeah. So Sylvia will send you a reminder of the link. You need to sign into that with your MSS email. I'd like to thank you very much for this wonderful presentation. Congratulations on all the work you're doing to continue to advance this field, and we will make sure to check for proteinuria in our patients and send them to you. Thanks everyone for attending, and we'll see you at the next session. Bye-bye.